Hi, this is a basic review of Chapter 8, the digestive system. So as we start with every chapter, we look at the related combining forms. And again, please take note, there's 2 for the mouth, there's 2 for the large intestine, 3 for the rectum and the anus, and then we have the accessory organs with the liver, gallbladder, and pancreas. So when we look at the structure of the digestive system, it's broken up into different parts. Okay. The upper GI is the mouth, the pharynx, the esophagus, and stomach. And the lower GI tract is the small intestines, large intestines, rectum, and anus. And then we have the accessory organs, which are the liver, gallbladder, and pancreas. So as we look at the picture here, we can see that the digestive system starts at the mouth. It goes all the way back through. We include the salivary glands, the pharynx, the esophagus, goes down into the belly. From there, it goes into the small intestines to the large intestines, then out through the rectum. We also see those accessory organs, the liver, and underneath, tucked here, under the liver is the gallbladder. That's going to be on the right side of the body. And the pancreas is here, and that's going to be in the left side of the body. So with the oral cavity, again, we know it as the mouth, and it's going to include everything that we typically know with the oral cavity: the lips, the hard and soft palate, salivary glands, tongue, the teeth, the periodontum, so all of those things. The lips, again, surround the opening to the oral cavity. And our lips play a role in eating, breathing, speaking, and expression of emotion. And you can see that when somebody's upset, they kind of purse their lips, or if they're having trouble breathing. As we take deep breaths, we will kind of put our lips together. So all of that plays a part. To be honest, again, I'm not going to ask tons of questions on the oral cavity, but just so you know, the gingiva is going to be here, which is the gum. The lip is here. We have the soft palate and the hard palate. The hard palate is towards the teeth. The soft palate is back here in the back of the throat. And that comes into play. Why it's important is because it's more soft tissue rather than a hard, a hard forming surface. So the back of this throat, which is soft tissue, if we don't have good musculature in it, when we go to sleep at night, that's when we talk about sleep apnea, where it actually relaxes, it cuts off the airway, and we can't breathe. So that soft palate plays a big role in not just the digestive system, but also other systems as well. Okay. The palate, again, we talked about the hard palate, and then the soft palate. The uvula is back there in the back of the throat. It plays an important role in swallowing and speech, but it also plays a role with snoring. The tongue is actually a really muscular organ. We need our tongue to be able to chew, to speak, and to swallow. A lot of patients who have issues, who have a stroke or have some type of other issue, really have to relearn how to swallow with a speech language pathologist because it affects their muscles and the nerves that innervate it. Sublingual is going to mean under the tongue. So again, if we do that breaking down of the medical terms, we can see that. The periodontal area, it actually is supporting and surrounding the teeth. The gingiva is actually, it's a mucous membrane covering the bone and surrounding the neck of the teeth. We also call that a gum. Okay, so the gingiva is our gums. Dentition, this is the way our teeth are. And so our natural teeth are arranged in upper and lower jaws. We have cuspids, which we use for biting and tearing. So as we're eating a piece of hard bread, we can rip it because of our incisors and canines. Our premolars, or bicuspids, and molars are the teeth in the back, and we use those for chewing and grinding our food. So it makes it easier to swallow for us. So again, here's the jaw with all of our teeth. I am not going to show you a picture of teeth and ask you which one is which. That will be for your dental hygiene classes and anatomy. The important thing to know here are primary dentation. So these are baby teeth. It's deciduous dentition. There's only 20 teeth. They erupt early in childhood, some earlier than others. Those do come out. They're born, babies are born with those other teeth in place. The permanent dentation comes out. There's 32 teeth. They're going to push those primary teeth out, and then we're going to get additional 12 teeth in the back of the mouth. Again, the crown of the top is the top portion of the mouth. The tooth that we can see is covered with enamel, which is really one of the hardest substances in the body. The root is what holds our teeth in place, and the cervix of the tooth is actually where the crown and the root meet. Again, just a nice picture there. The dentin is actually the bulk of our tooth, but the pulp cavity is where is in the crown and then the roots of our teeth. So if you've ever had to have a root canal, this is where they go in, to that pulp cavity, to go in and get those blood vessels and nerves cleaned out, because there's some type of infection in there. And if you've ever had an infection or a problem with one of the roots in your teeth, you definitely know it, because it is really, really painful. Saliva, again, it's that moisture in our mouth. It actually is the first part of the digestive process, because it lubricates our food so we can chew and swallow it with less issue. It also contains amylase, which is the first step in the chemical digestion as well. We have a physical breakdown of food, but we also have a chemical digestion of food. So here we're talking about the salivary glands. Here's the parotid gland. It's located right in front of the ear. Our sublingual salivary glands are going to be located under the tongue, and the submandibular glands are located on the floor of the mouth near the mandible. So there's three different ones: the parotid, which is by the ear, sublingual, which is under the tongue, and submandibular, which is under the mandible. The pharynx then is a common passageway for both the respiratory system and the GI system. Air and food pass through this. This is a huge, plays a huge role in swallowing, and the medical term for that is deglutition. The epiglottis actually opens and closes at the top of the trachea to prevent food and liquid from moving from the pharynx into the trachea during swallowing. So that's why we don't laugh or take a breath while we're swallowing, because that epiglottis is open and it allows that food and that water to pass. And we do not want that. That causes us to choke. The esophagus is a muscular tube that it's specifically for the passage of ingested food from the pharynx to the stomach. At the bottom of that, there is a lower esophageal sphincter. And this is going to be really important when we talk about GERD and some of the other diseases that are associated with it. This sphincter is actually a muscular ring between the esophagus and the stomach, and it relaxes when we are eating, and it allows food into the stomach, but then it contracts or it closes to help those stomach contents from regurgitating or coming back up through the esophagus. The stomach, it has different parts. We've got the fundus, which is the upper part. The main portion is the body. and the antrum is the lower portion of the stomach. There are rugae, which are actually folds in the mucosal membrane of the stomach. And what that does, it allows the stomach to stretch or get smaller as we eat. So as we eat a big meal, that helps the belly be able to expand to hold that meal until it starts to break down and move through the GI system. At this point, there in the stomach, there are different types of gastric juices, enzymes, hydrochloric acid that actually start to help that chemical breakdown of food again. Now, at the end of the stomach, before it goes off into the small intestine, we now have something called the pyloric sphincter. And again, just like the other one, it's a ring-like muscle, but this is at the base of the stomach, and it controls the flow of that partially digested food from the stomach to the duodenum. The pylorus, again, is that narrow passageway, connects the stomach to the small intestine, hence the name pyloric sphincter. Again, we have the picture here. Here's the esophagus. We have the fundus of the stomach, the body, and then we have the atrium here. Here is that pyloric sphincter, and right here is that lower esophageal sphincter. The small intestine extends from that pyloric sphincter to the first part of the large intestine. And there are three different parts to this. Excuse me. Sorry, I had a little coughing fit there. There's three sections of the small intestine. The duodenum. Now, some people are going to pronounce this duodenum. We're not going to argue with them, but technically the pronunciation is duodenum. The jejunum, which is the middle part, and the ileum, which is the last and longest part of the small intestine. Please note the spelling. You will notice it's ileum, which is for the small intestine. The ileum, which is part of the hip bone, is IUM. So it's very important that you notice the spelling here. The large intestine then extends from the small intestine to the anus, and the function of the large intestine is to prepare waste products. So we have different parts of the large intestine. We have the cecum, the colon, the rectum, and the anus. So when we look at this picture, we see the cecum here. Here's our appendix, which is just dangling here. We have the cecum. We have the ascending colon that goes across with a transverse colon to the descending colon, to the sigmoid colon, to the rectum, and then out through the anus. Again, the cecum lies on the right side of the belly, of the abdomen. We have that ileocecal sphincter, and it controls the flow from the ileum into the cecum. And again, we talked a little bit about the appendix. The appendix is actually a lymph tissue, hangs from the lower portion of the cecum. Some people still say they don't know what the function of this is, but it sure can cause problems if you get appendicitis. Again, ascending colon, transverse, descending, and sigmoid colons we talked about in the image. Then the rectum and anus. So our accessory digestive organs, they absolutely play a huge part of the digestive process, but they truly are not part of the GI tract. They have other functions besides that of the other than the digestive system. So the liver is actually our largest organ in the body. It has so many functions. One of the biggest functions of our liver is it actually removes all the toxins from our blood and turns that food into fuel or nutrients. It actually helps break things down, and it's really, really important. Bilirubin actually causes that yellow-green color of the bile, and the bile then is secreted by the liver and then aids in the fat digestion. So as we look here, we can see the liver. Okay, we see all of this duct work. We have something called the cystic duct, and so the bile is actually um, made in the liver. What happens then, it's concentrated and then stored, travels down these different ducts, it then is transfers to the gallbladder, and it's concentrated and stored for when we eat. When our body senses there is something that we've eaten, that there's fat, then the gallbladder actually contracts and secretes the bile into the small intestines to help digest those fats. Okay? Then we have the pancreas as well. So we talked a little bit about that biliary tree. And the gallbladder being under the liver stores concentrated bile. If we look at cholecystic, okay, pertaining to is our IC, gall, and then bladder. Okay. The pancreas, again, is located behind the stomach. It plays a huge role in our endocrine system. And it plays a big role in the digestive system as well. Not only is the gallbladder secreting those acids into the small intestines, but the pancreatic juices also are being excreted and being dumped in the small intestines. And that actually helps neutralize the stomach acids that are in there that are helping it break down. So how does our food get broken down so we can use those as nutrients? Well, those digestive enzymes we've talked about, it actually causes chemical changes in our food. And then what happens is as it gets broken down, there's different types of nutrients in those foods. And so we have primary or macronutrients. These are going to be our carbs, our fats, and our proteins. The three things that we use, if you check your labeling on your food, those are the things that carry calories with them. We also have those essential micronutrients, those vitamins and minerals that are so, so important. So with the metabolism, those chemical reactions actually change how those things work. And so we have two different parts to that. There's sorry. Sorry, guys, I got a little bit of a cough here. We have two different, we can have an anabolic reaction, and then there's a catabolic reaction. The anabolic is going to build up cells and substances by using those nutrients that have been broken down. They need those in the development of cells and substances in the body. The catalyst, or the catabolism, is actually breaking down cells and substances. So one is building up, one is breaking down. Absorption, and this is so very important. Once that takes place, the complete digestion of those nutrients and their transportations to the cell, that's when absorption takes place. And so in the small intestine that's covered with mucosa, and there's finger-like projections called villi that actually grab those nutrients and grab those things to be able to pull those in so we can use them. The lacteals that are there are lymphatic structures that actually absorb fats and fat-soluble vitamins that can't be transported directly into the bloodstream. We need them, but we can't get those fats or fat-soluble vitamins through the membranes. So those lymphatic structures pull those in, so those can be used in a different way. This is where issues take place with nutrition. When you hear somebody has malnutrition, or they have some type of digestive issue where they're not absorbing enough, salts, proteins, iron. This is where that malnutrition piece comes in, if the body's not able to pull it in and metabolize that. Mastication is actually the chewing of food. A bolus is actually what there is, the mass of food that's in our mouth that we are ready to swallow. And then what happens is peristalsis takes place. As we swallow, that peristalsis is that wave-like movement of those involuntary muscles that move the food through the digestive system. We don't just swallow it and it goes down into our esophagus and just naturally by gravity gets down to the stomach. Peristalsis is there, and that wave-like motion takes the food down through the esophagus and into the stomach. It actually works through the small intestine, the large intestine, and all the way through to the anus. The stomach is continually is breaking down the food again by those gastric juices and digestive enzymes. Chyme is what that as we swallow that food, as it goes through that process and gets in the stomach and mixes with these enzymes and the acids, it's called chyme, and that's a semi-fluid mass of partially digested food that comes out of the stomach through the pyloric sphincter, and that chyme then goes into the small intestine. Again, the role of the small intestine, the duodenum, it's mixing the chyme with pancreatic juice and bile. It then travels down into the jejunum, which continues the process of digestion as those extra enzymes break down the food even more. And then when it hits the ileum, that's when the absorption of the nutrition takes place. The large intestine, it's kind of a holding tank. What it does is it holds our body's solid waste. We also defecate, or defecation is when we have a bowel movement. And with the large intestine, there is a lot of bacteria that if it goes anywhere else in our body is going to cause havoc. E. coli is an example. That's a normal flora in our digestive system in the large intestine. But what that does, it actually helps fight infections that could come up. So again, maintaining homeostasis, we need that E. coli and those other gut microflora that are there to maintain homeostasis so we don't get any infections. One of the things too with the large intestine, it not only holds the food, but if that mass of stool that's sitting in there, it also can reabsorb water. So if our brain says we need more water, what it will do is it will pull the water out of that stool and make it more formed and then be reabsorbed back into the body. Borborygmus is actually that rumbling noise we hear. We call it our stomachs growling. That's actually the rumbling noise, and that's the movement of gas through the intestine. That's actually what that is. Now, flatulence or flatus is actually when we let gas out of the body through the rectum, better known as farting or tooting, depending how old you are. My grandson would say he tooted. Bariatrics is one of the specialties associated with the digestive system. They actually work in preventing and controlling obesity. And we're going to be talking about the different types of bariatric surgeries that are available shortly. Dentists, this is really important. People are finally starting to realize the importance of oral health in the overall health picture. So these are people that are diagnosing, treating issues of the teeth and the tissue in the oral cavity. What's starting to happen is if you have any type of cavities or any type of oral breakdown, they will not let you go to surgery now until you have that taken care of. So they're starting to recognize how important oral care is in the overall health of our patients. Gastroenterologist, again, if we look at it, one who specializes in the stomach and small intestines. An oral or maxillofacial surgeon, again, they're going to fix face surgery, any type of jaw deformities. These are the people that we're going to go to get our wisdom teeth removed if we're having problems. Orthodontist, again, remember, a specialist in straight teeth. That is the literal definition of orthodontist. They're going to be putting braces on to align our teeth. Periodontists actually specialize in the gum or the tissue surrounding the teeth. And this is really important because if we don't have good gums holding the teeth, then we're going to lose the teeth because there's nothing to cover them and protect them. Proctologists is people who specialize in the colon, rectum, and anus. Registered dietitians are extremely important with the digestive system because they're the ones that are going to work with our patients and counsel our patients on improving their dietary intake. So if they are having issues, like we said before, of absorbing protein or iron, they're going to work with the patient to make sure that they're eating things that are high in iron or high in protein. The pathology of the digestive system, tissues of the oral cavities, there's a number of different things. Again, chylosis is one of the ones, and this is crack-like sores at the corner of the mouth. If we literally define this, it is a disease of the lips. Chylo is lips. So just realize that if we do a literal transition, that's what it would be. Herpes, you'll hear this all the time. This is when you get fever blisters on your lips or facial tissue. This is actually caused by that herpes simplex 1. And the problem is with herpes is once it's in the blood system, it's always in the blood system. It's a virus that's there. And so anytime you have stress or you're tired, or a lot of times surgery will actually activate that, and patients will all of a sudden have fever blisters, engorge on their lips, and you feel like you've got a baseball on there. Worst thing you can do is pick at them. It is a virus, so just trying to get it to dry up and to just settle down and get rid of that is the best thing. No picking. Be very careful because it is transmissible. And so kissing people, especially little ones who don't have immunity built up, can be very detrimental to their health. Leukoplakia, again, it's where you get white precancerous type lesions on the tongue or in the inside of the cheek. And you will actually see, it looks like a white piece of, or white portion on the tongue or on the cheek. Thrush, I'm going to rush through some of these. Stomatitis is actually an inflammation of the mouth. Stomatomucosis is actually a condition with of the mouth that has to do with fungus. Okay, myco is fungus or pus. Yeah, I'm sorry, myco is fungus. So any type of fungal disease. Very easy to have happen. People who use oral inhalers like Preventol, they need to rinse their mouth out and spit that out after each use, because if not, the medication that are in there and the propellants that are there can actually cause the patient to develop a fungal infection. So it can be problematic. Oral thrush, again, it's candida, and we see that a lot of times in little ones. Trismus is actually a restriction of opening the mouth. This can be caused by trauma, some type of surgery, or radiation of oral cancer. And then xerostomia is actually a lack of saliva due to something happening to the salivary glands. They're just not producing enough saliva for us. Cleft lip, cleft palate, they usually can occur together. This is when the palate in the mouth has that has not been formed properly. There are surgeries that they can do. They actually now are able to go in and do things before babies are born, but a lot of these things can be fixed after birth as well. Bruxism is when you grind your teeth. People that sleep and grind their teeth, they can automatically identify that as we go to the dentist because you can actually see that on their teeth. The tops of their teeth are kind of ground down. Dental caries, again, that is when we have a cavity. It's actually a bacterial destruction of the enamel and dentin. And dental plaque, that usually goes in between your teeth and gums, and it's that place where that starts to form the dental caries. And so when you go get your teeth cleaned, they dig with those little tools, and they're trying to get all that plaque off so it doesn't develop into caries. Halitosis is unpleasant odor. It is bad breath. Okay, coming from the mouth. So when you hear somebody has halitosis, you know that they're going to have very bad breath. Malocclusion is when there's any type of deviation from the normal position of upper teeth against lower teeth. So if you have an overbite, an underbite, anything like that. We've talked a little bit about the periodontal disease. Again, anytime the gums are affected, it can really cause us to lose teeth. That dental calculus will build up into tartar, which will then cause infections, which will inflame the gums, and then we have a lot of problems. So you have to be incredibly careful. A periodontist is different than a dentist. They specifically look and work with the gums. There's necrotizing ulcerative gingivitis as well, and that's abnormal growth of bacteria in the mouth, and it will actually cause the death of the gum tissues, and then we will lose teeth. Some of the other terms that we're going to see is dysphagia. If somebody has dysphagia, they're having difficulty swallowing. So maybe it feels like their food's getting stuck in their or in the esophagus, or they don't feel like they've got enough saliva to get it down. They've got to drink to get their food down. Maybe they're not chewing it well enough. All of those things can lead to dysphagia. Again, eosinophilic esophagitis is actually an immune system disease. It may come back up in the immune system. The eosinophils actually build up, and then they can cause an allergy to food, and that's problematic with certain patients. Gastroesophageal reflux disease is GERD, and that's when there's an upward flow of acid from the stomach to the esophagus. So that sphincter that's supposed to hold the food into the stomach from the esophagus is not working properly, and the acids are being able to come up in through the esophagus and sometimes scar the esophagus so badly that surgery has to be taken. So we're going to be talking about medications that you can use for those type of issues. There's strictures, which is a narrowing of the esophagus due to tissue damage or something that may have happened. Again, this is going to make it hard for people to swallow because they're going to have a smaller diameter in their esophagus to be able to swallow. Pyrosis is actually the burning sensation that you get with acid reflux. Esophageal varices are just like a varicose vein, but it's in the esophagus. So you have those swollen veins. And the problem with that is if that swollen vein pops, you are going to have blood. And so people may cough that up, they may vomit that up, or even if they don't do that, that blood is going to be going into the stomach and being processed all the way through the digestive system. And then we're going to notice that they're going to have a very black, tarry stool, because that blood has hematolized, and that it's going to now be black, and it's going to look it's a very distinctive look and smell. Hiatal hernia is where there's a portion of the stomach that protrudes up through an opening in the diaphragm. Can be very problematic if that gets twisted, or if that part that's up through the diaphragm cuts off blood supply. You can then have a real issue, and it can get infected, and the patient has surgery and they can't close them because there's an infection, and they have to keep open and heal from the inside out. Gastritis is just going to be an inflammation of the stomach lining. Gastroparesis is actually going to be improper functioning of stomach muscles, so you can't empty your stomach properly. And gastriuria is actually an excessive secretion of gastric juices and mucus. There's different types of ulcers that are out there. So there's peptic ulcers, and gastric ulcers. Again, gastric is going to be meaning stomach. Duodenal ulcers are going to be in that upper part of the small intestine. And then a perforating ulcer is actually one that actually erodes through the organ wall. And again, that's problematic because now it's going into the abdominal area, and we're going to get some infection with that. Anorexia is the loss of appetite. Dehydration is the loss of fluids. People aren't able to drink, or they may have to have fluids by IV to try to rehydrate them. Malnutrition is the lack of proper nutrition due to either the storage of food, poor eating habits, inability of the body to digest, absorb those materials. And so it may be that they're eating the right foods, but their body just may not be able to absorb it. Or maybe they're eating so terribly that when we look at processed foods, there is actually very little nutritional value in processed foods. So we're not getting enough of the nutrition we need in order to function properly. Malabsorption is when the small intestine is not able to absorb the nutrients that we need for our body to work properly. Obesity, this is one of the this is the fastest growing disease in the United States. And we're seeing this, and with obesity comes things like high blood pressure, diabetes, those type of things. So this is really, it's actually at epidemic portions in the United States. This is 20 to 30% over the established weight guidelines. And we look at that, there's 3 factors: age, height, and gender. Morbid obesity is when you weigh about 2 times that of what your ideal weight is, and your BMI is over 40. The great thing with the BMI now is that with electronic health records, it determines that for you when you put in the height and weight and gender of the patient. Dyspepsia is indigestion. Emesis is actually the regurgitation of stomach contents. So it's vomiting is the better, emesis is the word for vomiting. So if you think about it, reverse peristalsis is actually the process of vomiting, because instead of the peristalsis moving the food down, it's actually reversing it and it's coming out. Eructation is belching or burping. The hematemesis is when we vomit blood. That is never a good sign. If that happens, the patient should get to the emergency room very quickly. Hyperemesis is an extreme persistent vomiting, and this really is a problem. The patient becomes dehydrated. We see this a lot in early pregnancy. So if the patient has hyperemesis, they do have to be treated, probably hospitalized, rehydrated, in order for them to maintain homeostasis. Again, nausea is the urge to vomit, and regurgitation is when we burp up food into our mouth and it's disgusting. There's different types of disorders out there, and you're going to hear a lot about celiac disease. There is a difference between celiac disease and gluten intolerance, a big difference. Okay, so celiac is actually an autoimmune disorder, and if our body has a severe reaction to food that's containing gluten. It actually damages those little fingers that we talked about, those villi of the small intestines, and that leads to malabsorption, and that's a real issue. A lot of patients are not celiac, don't have celiac, but they could have a gluten intolerance, and what that causes is digestive distress. I love that term. Excuse me. Real stomach upset and problems because we eat gluten. It really doesn't cause intestinal tissue damage like celiac does, but it still can cause an awful lot of discomfort for the patient. People do have food allergies, and they will know that they have them when they eat the food. They could break out in a rash. There can be a number of different things, and these need to be identified with the doctor. When you go in, they ask about allergies. We make sure we talk about food allergies as well. Lactose intolerant, again, our body doesn't like dairy. We may not have the enzyme lactase that actually breaks it down, but there's great little pills you can choose or chew that actually helps with that and actually will help break that down. Colorectal carcinoma is colon cancer. Polyps. A polyp is just like a mushroom growth from the surface of any mucosal membrane. So you can have a polyp in your nose, in your intestine, anywhere there's mucous membrane, you can have a polyp. But they can be problematic. Some polyps may be benign in nature, but other polyps are malignant. So if you go in for a colonoscopy or an EGD and they see a polyp, they are going to take that polyp and they're going to send it for a pathology report to make sure that there's no malignancy with the polyps. Diverticulosis is the disease of the diverticulum. And so a diverticulate is actually like an outpouching of, if you look at the colon, it would act, instead of a polyp being on the inside, it actually is an external pouch. And the problem with that is if you just have diverticulosis, it means that you have diverticula, and it could be problematic. The things that cause issues are anything with seeds, like corn, sesame seeds, anything that could get inside that little pouch, stay there and get infected. That's when we get into diverticulitis. And that's when there's an inflammation or infection in that diverticula, which is very uncomfortable for patients. Enteritis is an inflammation of the small intestine. And again, it could be viral, it could be bacterial in nature. It just depends. An ileus is actually a partial or complete blockage of the small or large intestines. And that could be due to a decrease in peristalsis. If you go in to have abdominal surgery, they actually give you like a paralytic agent because they don't want that peristalsis going on as they're operating on your bowel or any part of your abdomen. So they'll give that agent, and what they hope happens is as that wears off, the peristalsis starts again. But we see this a lot post-operatively, that it doesn't start up by itself. So we have to kind of give it a kickstart. Now, there are two different things here. IBS is irritable bowel syndrome. Okay, IBS. And you're going to get a lot of cramping, abdominal pain, and you can either have constipation or diarrhea with that. They don't know what causes it. But IBD is not irritable. It's an inflammatory bowel disease. So that's very different. One is irritable, one is inflammatory. Okay, so these type of inflammatory bowel diseases are going to be things like ulcerative colitis and Crohn's disease. Ulcerative colitis is truly just ulcers through the colon, causes a lot of pain and irritation for the patient. Crohn's disease is another one of those autoimmune disease. And it can occur anywhere in the body, but the problem with Crohn's, it actually affects every layer of the tissue. And so it is very, very uncomfortable for patients. It can cause massive diarrhea no matter what they eat. It really is terribly uncomfortable. They do use a lot of medications, autoimmune medications, to try to help control this. Again, we talked about the intestinal blockages. Vulvar, wait, I volvulus is actually a twisting of the intestine, and that is really, really problematic because, again, it's going to cut off the blood supply, and anything past that can cause death of the tissue of the colon, and that is not a good thing. So they want to try to catch that as soon as possible. If not, and there's death to the tissue, the patient may end up with a colostomy, which is problematic. Inguinal hernias, again, that could just be a little bit of the bowel popping through the lower abdominal wall as opposed to the hiatal hernia, which is going through the diaphragm. Okay, strangulated hernias, again, if that is strangulated and the blood supply is cut off to that part of the colon, it is going to cause death of that tissue and going to be problematic. C. diff. C. diff is a nasty infection. It is a bacterial infection, and it is awful. We see this mostly in hospitals and long-term care facilities. And I will tell you, if you've ever smelled C. diff, you will never forget the smell. It has a horrific smell. They try to really, there is medication that helps control this, but they do have to be very careful with the use of antibiotics after that because they don't want to wipe out the good bacteria and let that rear its ugly head again. Dysentery, again, is a bacterial infection spread through food and water contaminated with human feces. Again, we can see this in migrant workers in areas that don't have good running water and bathroom facilities. We talked a little bit about E. coli. While it is a good thing in the large intestine, it is not a good thing in any other part of our body. So if we eat food that has got E. coli in it and we haven't cooked it so it kills it, we can get E. coli in the stomach or in the upper GI system, and that is going to be terribly problematic. Salmonella, again, is something that's directed through direct contacts of eating anything that's contaminated food, unpasteurized milk, cheese products, those type of things. Anorectal disorders and anal fissure is actually like a crack in the skin of the anus. Terribly, terribly painful because if you think about it, every time you're going to have a bowel movement, it is going to pass and it is going to be very, very uncomfortable. Bowel incontinence means that you can't control the excretion of the feces. Constipation means that it has been sitting in that large intestine too long and so much water has been pulled out of it. You now have turds of steel, I like to call them. Very hard for you to be able to pass that because it is so dry and so hard. Diarrhea, again, very loose, watery stools. That's when we have increased peristalsis and the muscles are moving the food and fluids way too quickly. So the water doesn't have a chance to be pulled out by the large intestine. And that's why we have such watery stool. Hemorrhoids, again, these are just varicose veins, either on the inside of the rectum or they can be on the outside. They can actually be an external hemorrhoid as well. Very, very painful. Happens a lot in people who are pregnant because there's so much pressure on the rectum. A lot of people who sit on the toilet a long period of time, or they do an awful lot of grunting and pushing. That pushes those veins and can cause hemorrhoids. A rectocele actually is a like a herniation into the wall of the vagina. Not a good thing to have happen. And again, this type of thing can happen from childbirth and pregnancy. There are a number of different types of abnormal stools that are out there. Hematochezia is actually the stool that has bright red blood. And believe it or not, that's an okay thing because that means that the blood is in the lower part of the GI tract. A lot of times that is hemorrhoid blood. If the blood has been in the stool for a long period of time, then it's going to be very dark, ugly looking black tarry stool. The melanin is again black, tarry, foul-smelling feces. Again, because remember, melanin means black. That's usually indicating some type of bleed in the upper GI because the body has pushed it through and the blood has metabolized. And so it's going to go from that beautiful red to a dark red color that looks black in the stool. Steatorrhea is actually a lot of fat in the stool. It can be very bad, very, very stinky. And I guess all poop stinks, but it has a very different smell again. It actually can be caused by pancreatic diseases if you have removal of your gallbladder or malabsorption. Remember, the gallbladder excretes that bile, that concentrated bile, to help break down the fat. If we don't have a gallbladder, we don't have any stored bile to be able to do that. Ascites is actually an abnormal accumulation of fluid in the peritoneal cavity. Usually we see this, and it is like when somebody looks pregnant. It is a result of severe liver disease. We see ascites associated with alcoholism very, very frequently. Hepatomegaly is an enlargement of the liver. Jaundice is actually due to an increase of bilirubin in the blood, and that's when we get a yellow discoloration of the skin, mucous membrane, eyes. We see this a lot in newborns, but they put them under the billy lights and they usually do well. Hepatitis, again, is inflammation of the liver. There's a number of different types of hepatitis that are out there. We have A, B, C, D, E, but they are all caused, they are usually caused by those viral infections. Cirrhosis is just a chronic degenerative disease of the liver. It can be due to a number of things. Alcoholism, if they have viral Hep B or Hep C. Again, there are now better treatments for Hep C. We never had it before, but we now have medication for that. And we're better monitoring the Hep B. Non-alcoholic fatty liver disease. This is when people get a large amount of fat in the liver, but they're not drinkers. And so they're having some liver dysfunction, but it's not due to alcohol ingestion. And again, non-alcoholic hepatitis, again, it's not really has anything to do. There's a lot of fatty accumulation, but it's not caused by alcoholics or by drinking. Again, can develop into cirrhosis, liver scarring, or even liver cancer. Some of the terms, cholangitis is going to be an inflammation of the bile duct. Cholecystitis is going to be an inflammation of the gallbladder. A gallstone is a hard, it's just a bunch of material that that collects. It's bile that just gets hard and forms a stone, and it loves to be able to block the bile ducts. So cholelithiasis is going to be a gallstone, a presence of that stones in the bile or the gallbladder. Different diagnostic procedures that we can do, abdominal CT, they can kind of look through there, they can do the ultrasound, and then we can always do cholangiography, because we can go in and with contrast see all the parts of the gallbladder. We can also do an enema. You place it in the rectum, you work the solution in, and then it will dislodge or break up the stool, and then we can go to the bathroom. An esophageal gastroduodenoscopy is an EGD. It actually is a scope they put down in the mouth, down through the throat. They look at the esophagus, the stomach, and the first part of the duodenum. Upper GI and lower GI series, again, are different. An upper GI, you're going to swallow. They're going to watch it through the mouth, down through the GI system. Lower GI is going to be done like an enema. They're going to inject the contrast and the air, and they're going to watch it as it goes through. So they are able to look and see if there's any types of blockages, abnormalities, anything like that. We also have stool samples, so being able to test a specimen of feces, we can do in multiple different ways. Anoscope is actually a much more rigid, larger scope, and it's just going to be doing the anus and the rectum. Capsule endoscopy is really cool. You swallow this big pill, and it takes pictures all the way through the GI system. And within a few hours, you actually poop it out, and then you're done. You wear a belt or some type of transmitter. You turn that in after it's been expelled. It will actually tell you that. And then they go ahead and develop the pictures and kind of take a look at what's going on. Colonoscopy is the entire colon from the rectum to the cecum. Sigmoidoscopy is going to be of the sigmoid colon, rectum, and anus, maybe a little bit of the descending colon. Some of the screening tools for colorectal cancer, Hemoccult. We can do this in the office. We can do this, patients can do this at home. It's that little flap-like thing. They have a little stick, they get a little bit of their feces, put it on, close it up, put it in an envelope, and bring it back to the office. But there's a new one that's really cool. It's Cologuard. It's a non-invasive stool test using DNA testing. And so what you do is they deliver it to your house. You put it in the toilet. You go to the bathroom, you seal it up, you send it back through UPS or FedEx, and they do that testing. Different treatments that we can use for the digestive system, antioxidants, vitamins, increasing our fruits and vegetables. That's really, really important. Probiotics. These are things that help aid in digestion, and they are everywhere. You can buy them over the counter. You can buy, some are less expensive, some are more expensive, but there's a lot of things going on with probiotics. Medications that are out there that we use in the digestive system, antacids, these are things that are going to be like Tums that help neutralize the acid. Proton pump inhibitors are prescribed medicines that are actually going to be, those actually decrease the amount of acid that's produced by the stomach. So it's not neutralizing it, it actually physically decreases the amount of acid. There's antiemetics, which help relieve nausea and vomiting. There's laxatives, and there's a ton of different kinds of laxatives that actually stimulate a bowel movement. If our patient's dehydrated, we can do an IV, or we can do oral rehydration therapy as well. Okay. Dental prophylaxis, again, getting your teeth cleaned. We have a great dental hygiene program here at our college, and you can get your teeth cleaned very inexpensively here. Um, so if you haven't had your teeth cleaned and you need to, go to the dental hygiene lab. They do a wonderful job. Dental implants, crowns, bridges, anything that may or may not be anchored to the jaw. There's been a lot of talk about implants lately, and they are not as people have not been in favor as much as they have been in the past. So it's going to be interesting to see what happens. A root canal is when the endodontist goes in. They clean out the root area and get that damaged pulp out. They take out the nerve so you don't have any more pain in that area. Gingivectomy is the removal of diseased gum tissue or gingival tissue. Sometimes they will actually do like a little skin graft if they have to take too much tissue out. Palatoplasty is a surgical repair of a cleft lip. Gastrectomy is a surgical removal of all or part of the stomach. An NG or nasogastric intubation is when you put a tube through the nose and it either provides nutrition for the patient or it pulls out the acid from the patient so they don't have a lot of stomach upset. Gastrostomy tube is when they put a feeding tube in for the patient that is not able to actually eat. TPN, total parenteral nutrition. Again, that's going to be IV solution, and they're going to get all their nutrition through that. I said we were going to talk a little bit about the bariatric surgeries, and I am. They do this to treat morbid obesity, and what the bariatric surgery does is it restricts the amount of food that's able to get into the stomach. The first one is gastric bypass surgery. So what they actually do is they staple a section of the stomach to make a really small pouch. And that causes and then they actually bypass part of that, and they bypass the first part of the small intestine. This is pretty invasive surgery, but some people have done very well with it. The lap band adjustable gastric banding is a little bit different. It's much less invasive. They simply put a band around the exterior of the stomach, and they can push fluid into it to restrict it more and more. And then there's endoscopic, oh boy, I can't even talk by the end of this, endoscopic sleeve gastroplasty. And that's when they actually go in, they suture the stomach to make it a small tube that reduces the capacity of what they can eat. There are endoscopic, I don't know why I can't say this. They can do this endoscopically, and it does require general anesthesia. And again, what it's doing is decreasing the amount of food that the patient can eat. So that's where the weight loss comes in. There's a lot of controversy with this as well. If anybody has any type of malnutrition, this would not be recommended for them because we already have enough issue if we're bypassing part of the small intestine. They may not be getting enough nutrients to be able to live. So this needs to be looked at very carefully. They do have to go through psychiatric counseling, do sleep tests. There's a number of things they need to do in order to have that approved. A colectomy is a surgical removal of all or part of the colon. A colotomy is actually an insertion into the colon. Diverticulectomy is the surgical removal of the diverticulum. So if we see a patient who has diverticulitis frequently, they're going to go in, they're going to snip those off, suture them up, so they don't have as many problems. Duodenoscomy. Again, there's an anastomosis, and what an anastomosis is a connection between two hollow tubes or structures. And so they take part of the small intestine and maybe connect it to the stomach, or they take part of the ileum and part of the duodenum and connect each other. They take out the part that's being affected. Ileectomy, again, is a surgical removal of the ileum, which would be problematic because that's where the nutrients come in. Ileostomy is an opening to the outside of the abdominal wall from the small intestine. And a colostomy is a surgical creation to the outside of the body from the colon. That can be temporary or permanent. Sometimes they just do it to allow the body to heal itself a little bit, and then they go back in and they try to anastomose those two areas back together so they don't have a permanent colostomy. We can also do a hemorrhoidectomy, which is a surgical removal of hemorrhoids. Proctopexy is a surgical fixation of a prolapsed rectum, which means like that rectum's actually hanging on the outside of the body. We have a hepatectomy, a surgical removal of part of the liver, and then a liver transplant. If the liver's not working properly for a reason other than liver cancer, they may be able to do a liver transplant. And the last two, cholecystectomy is an incision into the common bile duct to get rid of our gallstones, and a cholecystectomy is a surgical removal of the gallbladder. Whew, this was a long one, guys. The GI system is huge. So I hope that helped, and good luck on your test.